Welcome to this Smith+Nephew digital education module on time. This forms part of a series of modules you can access to develop your knowledge and understanding around wound care. My name is Gemma and I am one of the wound care specialists at Smith+Nephew, and today we will be discussing wound bed preparation with the main focus being on the edge of wound. E represents edge of wound, non-advancing or undermined. This is the final component of time, and it is the active division, migration and maturation of epidermal cells from the wound margin across the open wound. When we talk about non-advancing, this means that the wound is not making any progress, and undermining means that the wound bed is not attached to the wound edge, which is going to prevent the wound from making progress unless appropriately managed. Assessment of wound edges can indicate whether wound contraction and epithelialization is progressing, and confirm either the effectiveness of the wound treatment being used or the need for re-evaluation. A healthy wound bed and peri-wound are important to support progress. In a healing wound, the wound edges include a thin, pale pink to translucent wound margin, as seen here. The non-healing wound edge will be very different to this, which we will go on to. Epithelialization needs cell migration over the wound bed so that it can then attach to the edge of the wound. Factors contributing to a non-advancing wound edge are the same as those which cause delayed wound healing in general and ultimately keep the wound in an inflammatory state. High levels of matrix metalloproteinases, MMPs, may prevent cells at the wound edge from responding to healing signals in the wound. Therefore, it is important to address T, I, and M of time. A desiccated or macerated wound edge can also affect the progress, and the wound will not go on to contract, and this requires management interventions. A non-advancing wound edge may appear as epibole, as seen in the picture. This is a term used to describe wound edges that have rolled inward on themselves. Other examples of non-advancing wound edges include hyperkeratosis, which is a build-up of keratinocytes at the wound edge, a callus, which commonly occurs around neuropathic diabetic foot ulcers, which can be seen in the top right photo, or unattached or undermined, in which the edge of the wound is not connected to the wound bed, and that can be seen in the bottom right photo. The intervention goal for the non-advancing wound edge is to re-establish an open wound edge from which epithelial migration can occur. Diabetic foot ulcers, for example, often require sharp debridement of the wound and the surrounding callus. This is usually conducted by creating a saucer-shaped wound, giving the epidermal cells an easy path for migration. However, this is usually carried out by a skilled and competent practitioner. The clinician should also consider the condition of the peri-wound skin in assessing wound contraction. Dry or macerated wound edges may affect the ability for the wound to be able to contract. For undermined wounds, interventions to promote a moist healing environment may allow the wound edge to reattach to the wound bed. Examples of other interventions include negative pressure wound therapy, the use of growth factors and/or skin substitutes in the form of prescribed creams or emollients. To check your knowledge and understanding, try and answer the quiz questions. You have now completed this module. Take time to reflect on how you can take some of what you have learnt today and apply it to daily practice. There is a 15-minute presentation of this topic that will help deepen your knowledge. Thank you for your time today. Please remember to look at the other sections to access other modules to help you on your learning journey.